Hello there. So now let's move ahead with gastroenterology and let's see the next scenario. Now we have here a 51-year-old man presenting to the GP surgery with new onset jaundice, which started around 3 days ago. He has no abdominal pain, lost 5 kgs over the past month, drinks an average of 30 units of alcohol in a week, and he has been doing so since in his late 20s. There are no abnormal mass on palpation of his abdomen, and hemoglobin is 141, white cell count 4, platelet count 250, bilirubin level is 99, which is quite raised. ALT is 202, ALP is 539, GGT is 290, and albumin level is 36. Now, more than 50% of his bilirubin is conjugated. His observations are within the normal limits. What is the single most appropriate action in this case? So, one needs to consider pancreatic cancer in any patient with new onset jaundice over 40 years old. So, whenever there is a patient having new onset jaundice and the age is more than 40, we always have to consider pancreatic cancer. One needs to consider. So, jaundice can be found with tumors of the head of the pancreas due to biliary obstruction. Yes, obstructive type of jaundice can occur because of the tumor in the head of the pancreas due to biliary obstruction. Pancreatic cancer can present without pain, although pain becomes more apparent as the tumor progresses. Now, in some cases, gallbladder can be palpable, that is Courvoisier sign, but this was not the case in this question. So, in some cases, gallbladder can be palpable in some cases, which is called as Courvoisier sign, but this is not the case here. This patient needs to be seen by the gastroenterology team within 2 weeks, of which an urgent CT abdominal scan would be likely organized. So he has an obstructive jaundice picture, and GGT is very sensitive, but it is not at all specific. So in this case, raised GGT could be due to alcohol consumption or could be due to pancreatic disease. Now, there is no indication that this patient needs to be admitted urgently. He does not have a fever. He does not have abdominal pain or abnormal inflammatory markers to represent an acute infection. This patient is not having fever, not having any abdominal pain. He's not having any inflammatory markers in abnormal state. So the patient is not representing an acute infection. So this patient need not to be admitted urgently. Amylase is performed when acute pancreatitis is suspected. So serum amylase level is performed when we are suspecting acute pancreatitis rather than patients with suspected pancreatic cancer. In this patient, we are not suspecting acute pancreatitis. Therefore, we would not advise for serum amylase levels. Rather, we are suspecting pancreatic cancer here. Amylase level can be found raised in pancreatic cancers, but remember, in clinical practice, we would not request for amylase when suspecting pancreatic cancer, but instead a CT abdominal scan, which would be a better choice. So we have to consider an urgent CD abdominal scan for this patient, but first we have to refer this patient for suspected pancreatic cancer to gastroenterology team, and then there most likely an urgent CT abdomen would be carried out, and that is to be done in case of pancreatic cancer. So again, any patient with new onset jaundice over 40 years of age, we have to consider pancreatic cancer as well. And this obstructive type of jaundice in such patients can occur due to tumor of the head of the pancreas, which causes biliary obstruction, leading to obstructive jaundice. Pancreatic cancer can present without pain, although pain becomes more severe when the tumor progresses. In some cases, gallbladder can be found palpable. In some cases of pancreatic cancer, gallbladder can be found palpable, and this sign is called as Courvoisier sign. But here it is not the case, and most likely this patient, in this patient we are suspecting pancreatic cancer, so we need to refer this patient to gastroenterology team within 2 weeks, and an urgent CT abdomen would be most likely organized. There is obstructive jaundice picture. GGT is sensitive but not at all specific. Raised GGT can be due to alcohol consumption. It can also be due to pancreatic disease. So raised GGT can be due to alcohol consumption, and raised GGT can also be due to pancreatic disease. So GGT is very sensitive, but it is not at all specific. Now, there is no indication that this patient needs to be admitted urgently. Because the patient is not having fever, no abdominal pain, no abnormal inflammatory markers, so he's not having an acute infection state, so need not to be admitted urgently. Amylase level need not to be performed because it is not a case of acute pancreatitis. We are not suspecting that, rather we are suspecting pancreatic cancer. Amylase can be found raised here, but in clinical practice we have to remember, in a case where pancreatic cancer is suspected, we would rather advise an urgent CT abdominal scan, a CT scan of abdomen, rather than serum amylase levels. So that is about it, and let's move further. Now we have a 39-year-old woman admitted with central abdominal pain radiating through to the back. She has vomited several times in the last 24 hours, denies any diarrhea. Bending forward helps alleviating the pain. On examination, there is epigastric tenderness associated with guarding. She has a blood pressure of 170, respiratory rate 20, pulse rate 106, temperature 37.9. Amylase level is 1335, CRP is 214, white cell count is 19.6. What is the single best step in this management? They're asking single best step. So now we in this case we are having in option we have fluid resuscitation, analgesia, and nutritional support. Because this seems to be a case of acute pancreatitis, so fluid resuscitation, analgesia, and nutritional support, this seems to be the single best step in management. So the likely diagnosis is acute pancreatitis. Given the elevated serum amylase levels, the initial treatment for acute pancreatitis is supportive. It includes early fluid resuscitation, analgesia, and nutritional support. Parenteral nutrition is only used when the enteral route is not tolerated. If patient can't tolerate enteral nutrition, then we will carry out parenteral nutrition, or if it is not meeting specific caloric requirements, or if it is not sufficient enough. Surgical debridement may be required where there is a proven infection. So surgical debridement can be required if there is proven infection and necrosis. Note that laparoscopic surgical debridement has largely been replaced by newer minimally invasive techniques such as transgastric endoscopy and video assisted translumbar retroperitoneal necrosectomy. So these are new techniques which have replaced laparoscopic surgical debridement. So certain new minimally invasive techniques have been introduced which have even replaced laparoscopic surgical debridement. These are transgastric endoscopy, and video assisted translumbar retroperitoneal necrosectomy. Video assisted translumbar retroperitoneal necrosectomy, followed by closed lavage of infected pancreatic necrosis, and so urgent laparoscopy is not the answer here. Followed by closed lavage of infected pancreatic necrosis. So in this case, urgent laparoscopy is not the answer. Also remember that there would be need to be some evidence of necrosis before surgical debridement is considered, because there is no evidence of necrosis here. Therefore, surgical debridement would not be the answer to go. Intravenous antibiotics, IV imipenem, can be started in moderate to severe cases even without evidence of infected necrosis. They should preferably follow a percutaneous aspiration of peritoneal fluid for culture. So first we have to carry out a percutaneous aspiration of peritoneal fluid for culture. However, in this case, fluid resuscitation, analgesia, and nutritional support are more important than just antibiotics. 60% of acute pancreatitis in adults in the UK are due to gallstones, and thus cholecystectomy can be considered, but should only be considered only after the initial symptoms of acute pancreatitis have been resolved. So likely diagnosis is acute pancreatitis here, and initial management of acute pancreatitis involves fluid resuscitation, analgesia, and nutritional support. And apart from that, we have to rule out other options as well. Now, parenteral nutrition, we can carry out parenteral nutrition if enteral nutrition is not tolerated or it is not sufficient. Now, if there are evidences of infection and necrosis, then surgical debridement may be required. For surgical debridement, there is laparoscopic surgical debridement, but this has been replaced by new minimally invasive techniques like transgastric endoscopy and video-assisted translumbar retroperitoneal necrosectomy, followed by closed lavage of infected pancreatic necrosis. So urgent laparoscopy is not the answer here. We have to remember that there needs to be some evidence of necrosis before surgical debridement is considered. IV antibiotics, IV imipenem, can be started in moderate to severe cases of acute pancreatitis without any evidence of infected necrosis, and this should happen. Antibiotics should be started after percutaneous aspiration of peritoneal fluid for culture. However, in this case, the other option, that is fluid resuscitation, analgesia, and nutrition support, seems more important than just antibiotics. Another important factor is 60% of acute pancreatitis cases in adults in the UK are due to gallstones. So cholecystectomy can be considered, but it is only considered after the initial symptoms of acute pancreatitis have been resolved. Let's quickly go through acute pancreatitis once. So the vast majority of cases in the UK of acute pancreatitis are due to gallstones and alcohol. A popular mnemonic to remember the causes of acute pancreatitis is get smashed. That is gallstones, ethanol, trauma, steroids, mumps, then autoimmune disorders, and Ascaris infection, and then scorpion venom, hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia. After that, ERCP, that is endoscopic retrograde cholangiopancreatography. Then drugs. Drugs like azathioprine, mesalazine, furosemide, steroids, sodium valproate, pentamidine, etc. So these are the causes. Get smashed are the causes of acute pancreatitis, mainly caused by gallstones and alcohol in the UK. But other causes are get smashed, that is gallstones, ethanol, trauma, steroids, mumps, autoimmune disorders like polyarthritis nodosa and ascaris infection. Then scorpion venom can cause acute pancreatitis. Then hyperchylomicronemia, hypertriglyceridemia, hypercalcemia, hypothermia. Then ERCP and certain drugs like azathioprine, mesalazine, pentamidine, sodium valproate, furosemide, etc. Clinical features involve sudden severe epigastric or central abdominal pain radiating to back and sitting forward may relieve it. Second, vomiting is prominent here. So, sudden severe epigastric or central abdominal pain radiating to back and sitting forward may relieve it. Vomiting is prominent. Other features which we have to look out for are tachycardia, fever, jaundice, shock, rigid abdomen with local or general tenderness, and periumbilical bruising, that is Cullen's sign. So other features, apart from sudden severe epigastric or central abdominal pain radiating to back, which gets relieved on sitting forward, and vomiting. Other features are tachycardia, fever, jaundice, shock, rigid abdomen with local or general tenderness, and Cullen's sign. Cullen's sign is periumbilical bruising. Now, investigation, serum amylase level is raised more than 1000 or around 3 times the upper limit of normal. However, lipase levels are more sensitive and more specific. Second, CT scan with contrast enhancement may be diagnostic, where clinical biochemical results are equivocal. So, two investigations. First is raised serum amylase levels more than 1000 or more than 3 times the upper normal limit. Lipase levels are more sensitive and more specific though. Second is CT scan of abdomen. Contrast enhanced CT scan of abdomen may be diagnostic. Management is resuscitation with IV fluids, IV analgesia, nutritional support, that is parenteral feeding, and IV antibiotics in severe cases. So this is about acute pancreatitis. Let's quickly go through the chart. So as we can see here, presentation is upper abdominal pain radiating to the back, relieved on sitting forward. Then we have tachycardia, vomiting, shock, Cullen's sign, that is periumbilical bruising, acute pancreatitis. Then causes we studied get smash. Here it is indicating bad hit. There are biliary such as gallstones and alcohol, drugs, hypertriglyceride, hypercalcemia, idiopathic, and trauma. The most important two risk factors that we must know are gallstones and alcohol. Cullen's sign. This is an example of Cullen's sign, periumbilical bruising in case of acute pancreatitis. Now, investigations are first serum amylase levels increased more than 3 times the normal upper limit. Lipase levels are also raised. Lipase levels are more sensitive, more specific. Second, CT scan, contrast enhanced CT scan. Lipase is more specific than amylase. Treatment is with IV fluid, that is IV fluid resuscitation, then nutritional support, parenteral nutrition, then analgesia, painkillers, IV antibiotics if severe. Surgery is only required when pancreas is necrosed. If there is necrosis, then surgical debridement may be required. We have to switch to parenteral feeding if patient is unable to tolerate oral feeds. So again, majority of the cases in the UK of acute pancreatitis are caused by gallstones and alcohol. Mnemonic is get smashed, that is gallstones, ethanol, trauma, steroids, mumps, Then autoimmune disorders like polyarthritis nodosa and ascaris infection, then scorpion venom, hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia, then ERCP, and drugs like azathioprine, pentamidine, furosemide, sodium valproate, mesalazine, etc. Then clinical features include sudden severe epigastric or central abdominal pain radiating to back, and the pain becomes better, or the pain uh, is relieved on sitting forward. So sudden severe epigastric or central abdominal pain radiating to back, which becomes relieved on bending forward or sitting forward. Then vomiting is prominent. Second thing, other features are like tachycardia, fever, jaundice, shock, and the abdomen is rigid with local or generalized tenderness. Then Cullen's sign is important in acute pancreatitis. Cullen's sign is periumbilical bruising. Investigations are raised serum amylase level more than 3 times upper normal limit, and lipase is more specific and more sensitive than amylase. Contraction and CT scan, management, resuscitation with IV fluids, IV analgesia, nutritional support, parenteral feeding, IV antibiotics. And in chart, new thing we studied is it is the same here. Even in the chart, there is no new point here. The two most important risk factors which we must know are gallstones and alcohol. This is main. Upper abdominal pain radiating back, relieved on sitting forward, tachycardia, vomiting, shock, periumbilical bruising, that is Cullen's sign. And after that, investigation we studied, and these are the treatment. IV fluid, nutritional support, painkillers, IV antibiotics, surgery when necrosis is there. Okay, so now let's move ahead. Now there is a 43-year-old lady presenting with jaundice. Skin excoriations were seen on the physical examination. Blood test shows raised alkaline phosphatase, mildly raised alanine transaminase. Now, anti-mitochondrial antibodies are found to be positive. What is the single most likely diagnosis here? So, anti-mitochondrial antibodies, this is the hallmark of primary biliary cirrhosis. Anti-mitochondrial antibodies. So the diagnosis here is primary biliary cirrhosis. The classical presentation is itching in a middle-aged woman, as we see here. It's a 43-year-old lady, middle-aged, and there is itching, there is pruritus, skin excoriations are there on physical examination, which are due to itching, due to pruritus. So classical presentation of primary biliary cirrhosis is itching in a middle-aged woman. Often asymptomatic and diagnosed after finding elevated alkaline phosphatase on routine LFT, and lethargy, sleepiness, and pruritus may precede jaundice in this case. There is an association with Sjogren's syndrome. Anti-mitochondrial antibodies are the hallmark of this disease. So we have, in case of primary biliary cirrhosis, to remember, we have to think of the M rule. Now, what is the M rule? M rule is IgM, anti-mitochondrial antibodies, and middle-aged female. So first is the IgM antibodies, then anti-mitochondrial antibodies, and middle-aged female. This is the M rule for primary biliary cirrhosis. So diagnosis we saw, it is primary biliary cirrhosis. There is classical presentation of itching in a middle-aged woman, primary biliary cirrhosis, because there are skin excoriations due to pruritus or itching. Now often it can be asymptomatic, and but It is usually diagnosed with after finding elevated alkaline phosphatase on LFT. Now, in these cases of primary biliary cirrhosis, lethargy, sleepiness, and pruritus may precede jaundice. And this primary biliary cirrhosis has an association with Sjogren's syndrome, and anti-mitochondrial antibodies are the hallmark of this disease. Anti-mitochondrial antibodies are the hallmark of primary biliary cirrhosis. The M rule is IgM, anti-mitochondrial antibodies, and middle-aged females. Now let's read a little more about primary biliary cirrhosis here. So primary biliary cirrhosis, we have to remember certain things. First, primary biliary cirrhosis, also called as primary biliary cholangitis, it's an autoimmune disease of the liver, which results in slow progressive destruction of intrahepatic bile ducts. The destruction leads to cholestasis, followed by fibrosis and eventually cirrhosis. Presentation: 50% of the patients with primary biliary cirrhosis are asymptomatic. If symptoms are there, they consist of fatigue, pruritus, and obstructive jaundice, which is a late sign. So, in the exam, patient would more likely be a female because the ratio of primary biliary cirrhosis found in women to men is 9:1. Family history of autoimmune conditions like thyroid disease, uh, celiac disease, and Sjogren's syndrome, scleroderma, these are common. Thyroid disease, Sjogren's syndrome, celiac disease, scleroderma, these are commonly seen. Family history of these autoimmune conditions. Investigations: alkaline phosphatase is raised, therefore there is cholestatic picture. Then anti-mitochondrial antibodies are positive. So these are the two investigations. Alkaline phosphatase is raised, that is cholestasis, and anti-mitochondrial antibodies are positive. Management involves ursodeoxycholic acid and cholestyramine. So primary biliary cirrhosis or primary biliary cholangitis, it is an autoimmune disease of the liver resulting in slow progressive destruction of intrahepatic bile ducts. This destruction further leads to fibrosis and eventually cirrhosis of liver. 50% of the patients are asymptomatic. If they are symptomatic, the symptoms can be like fatigue, pruritus, itching, and jaundice, which is a late sign, obstructive jaundice. Patient is more likely to be a female because the ratio of female to male in primary biliary cirrhosis is 9:1. So itching in middle-aged women, it's like a classical presentation. Now, family history of autoimmune conditions like thyroid disorders and celiac disease, scleroderma, Sjogren's syndrome is common association. Investigations: alkaline phosphatase raised, cholestatic picture, and anti-mitochondrial antibodies are positive, which is a hallmark of primary biliary cirrhosis. And management is by ursodeoxycholic acid and cholestyramine. Now let's go through the chart. 3M, anti-mitochondrial antibodies, middle-aged female, and IgM. Presentation is pruritus, skin excoriation, skin excoriations, and jaundice. Alkaline phosphatase is raised, associated with Sjogren's syndrome, celiac disease, thyroid disease, scleroderma, autoimmune diseases. Female predominance, ratio of women to men 9:1. Memory tool, how to remember women's breast, and PBC, primary biliary cirrhosis. Primary sclerosing cholangitis is more commonly found in men. Treatment is ursodeoxycholic acid and cholestyramine. So 3M, middle-aged female, anti-mitochondrial antibodies, and IgM. Presentation: pruritus, itching, skin excoriations, then jaundice, and alkaline phosphatase is raised. Alkaline phosphatase is raised, associated with autoimmune conditions like Sjogren's syndrome, celiac disease, thyroid disease, scleroderma, female predominance, women to men 9:1 ratio, women's breast B for breast and B for biliary cirrhosis. So it can be used to remember. Now treatment is by ursodeoxycholic acid and cholestyramine. Let's go through primary sclerosing cholangitis as well at the same time. So here we also have presentation with pruritus, skin excoriations, jaundice, alkaline phosphatase is raised. This is associated with ulcerative colitis. It is found more in men. Men to women ratio is 7:3. So how we can remember men's stick? We know what it means. And as for stick and as for sclerosing cholangitis. So sclerosing cholangitis, it is more commonly found in men. Now treatment, supportive treatment is supportive cholestyramine. There we had ursodeoxycholic acid and cholestyramine. Here we have supportive treatment, that is cholestyramine, which reduces the itching, and liver transplantation for end stage disease. Okay, so now let's move ahead now. Now we have a 44-year-old man who is seen in his GP with a history of fatigue, pruritus, abdominal pain over the past 3 months. His medical history includes ulcerative colitis. He does not drink alcohol or smoke. He has no history of weight loss. His blood test is showing bilirubin 52, ALT 123, ALP 480, AST 159, GGT 290, albumin 38. More than 50% of his bilirubin is conjugate. What is the single most likely diagnosis here? Now, this is a case of primary sclerosing cholangitis, what we were studying right now, just right now, what we studied. His blood test shows a cholestatic picture because raised ALP, alkaline phosphatase, is much more than ALT. So it is a cholestatic picture. GGT is also raised in patients with primary sclerosing cholangitis. Now, viral hepatitis tends to have ALT raised more than AST. It would not show a cholestatic picture. In case of viral hepatitis, ALT would be raised more than ALP. In case of cholestatic picture, cholestasis, ALP would be raised more than ALT. ALP would be raised more than ALT. Now, the two major clues to pick primary sclerosing cholangitis over primary biliary cirrhosis are: first is the sex of the patient. It has male predominance. We know that primary sclerosing cholangitis, and the patient here is a male. Associated disease is, we know primary sclerosing cholangitis is associated with ulcerative colitis. It is associated with inflammatory bowel diseases like ulcerative colitis, whereas primary biliary cirrhosis is associated with autoimmune diseases like celiac disease, thyroid disorder, Sjogren's syndrome, scleroderma. So that is the thing. Now, quickly going through primary sclerosing cholangitis, it is a progressive disease of the liver and gallbladder resulting from scarring of the bile ducts. This scarring leads to cholestasis followed by fibrosis and eventually cirrhosis. So, primary sclerosing cholangitis is a progressive disease of liver as well as gallbladder, which is resulting from scarring of the bile ducts. In this, there is no autoimmune destruction of intrahepatic bile ducts. In this, there is scarring of the bile ducts. And due to scarring of the bile ducts, there is progressive disease of liver and gallbladder, because this scarring leads to cholestasis, which further leads to fibrosis and cirrhosis. So, progressive disease of the liver and gallbladder resulting from scarring of bile ducts, and scarring leads to cholestasis and further leading to fibrosis and eventually liver cirrhosis. Presentation, it can present asymptomatically. If symptoms are present, they can be fatigue, abdominal pain, pruritus, obstructive jaundice. Patient would more likely be a male. Men to women ratio is 7:3. Strong association with inflammatory bowel disease, especially ulcerative colitis. 75% of the patients with sclerosing cholangitis have inflammatory bowel disease. Now here, conjugated bilirubin level would be high in this patient. So here in this patient, bilirubin level would be high. Uh, First is elevated conjugated bilirubin level, ALP, alkaline phosphatase is raised, cholestasis more than 3 times the upper limit, and GGT is also raised. Basically, the blood results would show a cholestatic picture. So in cholestasis, due to cholestatic picture, ALP is raised more than 3 times the normal limit, upper normal limit, and also bilirubin is raised, conjugated bilirubin, mainly conjugated bilirubin is raised, and GGT is raised. ERCP is the most specific test which can be conducted. Management involves liver transplantation and supportive treatment like cholestyramine. So again, it is a progressive disease of liver gallbladder resulting from scarring of the bile ducts. Scarring leads to cholestasis, further leading to fibrosis and cirrhosis. It can present asymptomatically, but if symptoms are present, they can be like fatigue, abdominal pain, pruritus, obstructive jaundice. Patient would be more likely a male, 7:3 ratio, strong association with inflammatory bowel disease like ulcerative colitis. 75% of the patients have inflammatory bowel disease. Investigations are elevated conjugated bilirubin level, increased conjugated bilirubin level, ALP would be raised more than 3 times, cholestatic picture, GGT would be raised, ERCP can be conducted, which is the most specific test here. Management is involves liver transplantation. Now let's move ahead. Before moving ahead, we can quickly compare both of them. First, primary biliary cirrhosis and primary sclerosing cholangitis. Primary biliary cirrhosis is autoimmune and idiopathic. Sclerosing cholangitis is also autoimmune and idiopathic. Primary biliary cirrhosis, female predominance, sclerosing, male dominance. Biliary association with autoimmune disorders like Sjogren, celiac, thyroid disorders, scleroderma, etc. And sclerosing association with inflammatory bowel disease, especially ulcerative colitis, pruritus, and here in biliary pruritus will be there, alkaline phosphatase is raised. Here also pruritus is there, alkaline phosphatase is raised. But in primary sclerosing cholangitis, ERCP, that is endoscopic retrograde cholangiopancreatography, ERCP is the most specific test in primary sclerosing cholangitis. In biliary cirrhosis, antimitochondrial antibodies are, which is a hallmark of this disease. Antimitochondrial antibodies are raised, are positive. Antimitochondrial antibodies are positive in primary biliary cirrhosis. Now management here, ursodeoxycholic acid and cholestyramine. Here the management in sclerosing would be liver transplantation and cholestyramine for itching. Transplantation is an end stage liver disease. Now let's move ahead. Now we have a 33-year-old pregnant woman who develops severe epigastric pain, nausea, vomiting at 35 weeks of gestation. She was diagnosed with preeclampsia 2 weeks ago. On examination, she has yellow sclera. Lab investigation shows a deranged liver function, low platelets, and low serum glucose, raised serum ammonia. What is the single most likely diagnosis here? So this is a case of acute fatty liver of pregnancy. Now, acute fatty liver of pregnancy and HELP syndrome, that is hemolysis, elevated liver enzymes, and low platelets. Both these syndromes have low platelets as well as deranged liver function. Both of them have acute fatty liver. Obviously, it has deranged liver function. It also has low platelets. So, low platelet and deranged liver function are part of both, part of the clinical picture of both acute fatty liver of pregnancy as well as HELP syndrome. However, low serum glucose or raised serum ammonia are more suggestive of acute fatty liver of pregnancy. So, raised serum ammonia level and low serum glucose and vomiting are also more commonly seen in acute fatty liver of pregnancy as compared to HELP syndrome. So, acute fatty liver of pregnancy and HELP syndrome, both of them have deranged liver function test as well as low platelet count, but the difference is low serum glucose levels and raised serum ammonia. Low serum glucose and high serum ammonia, that is only found in acute. It is more suggestive of acute fatty liver of pregnancy, and vomiting is also more common in acute fatty liver of pregnancy as compared to HELP syndrome. So let's study a little more about acute fatty liver of pregnancy. Let's see if we have a chart on this. Acute fatty liver of pregnancy. Okay, we don't. Anyway, so acute fatty liver of pregnancy is a rare form of jaundice in pregnancy. It occurs late in pregnancy and may be life threatening. The etiology of this is unknown. It is the part of spectrum of disorders related to preeclampsia. Differentiation from HELP, that is HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count. It can be difficult because signs and symptoms can overlap. But we studied low serum glucose levels, high serum ammonia, and vomiting. It can be used to differentiate. Now, risk factors. Preeclampsia in 30 to 60% of the cases. Second, first pregnancies. And third, multiple pregnancies. These are the risk factors: preeclampsia, first pregnancies, and multiple pregnancies. Presentation: it presents acutely with nausea, vomiting, abdominal pain, fever, headache, pruritus, and jaundice. So nausea, vomiting, abdominal pain, fever, jaundice, headache, pruritus. Symptoms tend to begin typically after 30 weeks of gestation. It may also appear immediately after the delivery. Severe hypoglycemia and clotting disorder may develop, causing coma and death. So, symptoms tend to begin typically after 30 weeks of gestation, and it may also appear immediately after the delivery. And severe hypoglycemia and clotting disorder may also develop, causing coma and death. Now, investigations are liver transaminase is elevated. ALT is typically elevated more than 500. Second, raised serum bilirubin. Third, hypoglycemia. Abnormal clotting with coagulopathy, prolongation of prothrombin time, and partial thromboplastin time. Biopsy would be diagnostic. Now, management, unlikely to be asked, but still, management would be we have to treat hypoglycemia, correct the clotting disorders, N-acetylcysteine, unlicensed use, and consider early delivery. So, acute fatty liver of pregnancy is a rare form of jaundice in pregnancy. It occurs late in pregnancy, usually occurs after 30 weeks of gestation. It occurs late in pregnancy after 30 weeks of gestation. It is a rare form of jaundice in pregnancy. It, it may be life threatening. Etiology of AFLP is unknown. It's a part of the spectrum of disorders related to preeclampsia. Differentiation from HELP syndrome can be difficult. HELP is hemolysis, elevated liver enzymes, and low platelet count. Now, risk factors. But how can we differentiate between AFLP and HELP? In AFLP, acute fatty liver of pregnancy, serum glucose would be low and serum ammonia would be high, and vomiting would be more common. It is more suggestive of AFLP rather than HELP syndrome. Risk factors of acute fatty liver of pregnancy are preeclampsia, then first pregnancy and multiple pregnancies. Presentation is nausea, vomiting, abdominal pain, fever, headache, jaundice, pruritus. Symptoms begin typically after 30 weeks of gestation, and it may also appear immediately after delivery. Severe hypoglycemia and clotting disorder may develop, leading to coma and death. So there may be severe hypoglycemia and clotting disorder in this acute fatty liver of pregnancy, which may lead to coma and death of the patient. Investigations are liver transaminase, that is ALT, is typically elevated more than 500. So liver transaminases are elevated. Serum bilirubin is raised. Then hypoglycemia is there. Abnormal clotting with coagulopathy. So there is prolongation of prothrombin time and partial thromboplastin time. So abnormal clotting with coagulopathy. Then biopsy would be diagnostic. So liver transaminase is elevated, ALT is elevated more than 500, serum bilirubin is raised, hypoglycemia, and abnormal clotting with coagulopathy. That is raised prothrombin time and raised partial thromboplastin time. Biopsy is diagnostic and management is treat hypoglycemia, correct the clotting disorders, and N-acetylcysteine, and early delivery. Now, how we will differentiate acute fatty liver of pregnancy from HELP syndrome? Now, in HELP syndrome, epigastric pain would be more. First, let's see the things which are clearly distinguishing. In HELP syndrome, there is no vomiting. In AFLP, there is vomiting. In HELP syndrome, there is no hypoglycemia. In AFLP, there is hypoglycemia. In HELP syndrome, serum ammonia level is not raised. In AFLP, it is raised. In HELP syndrome, there is no acidosis. In AFLP, there is acidosis. Now, vice versa, what are the things which are present in HELP, absent in AFLP? That is hemolysis. The first thing, the first letter. Hemolysis is present in HELP syndrome, absent in AFLP. So, vomiting, hypoglycemia, so low serum glucose, high serum ammonia, and vomiting. These are the three things present in AFLP, absent in HELP. Hemolysis is the one thing which is present in HELP, absent in AFLP. And acidosis is also something which is present in AFLP, absent in HELP. Now let's move ahead. Now let's take a small break and I'll be back. Okay, so now we have a 60-year-old man presenting with a lump in left supraclavicular region. He complains that he does not eat as much anymore because he does not have the appetite. He also lost 10 kg in the last 3 months. What is the single most probable diagnosis? So the lump in the left supraclavicular region is known as Virchow's note, and the clinical finding is called as Trocheer's sign. It is indicative of gastric carcinoma, carcinoma of the stomach, since it is one of the first visible spots where metastasis occurs. The weight loss, reduced appetite support the diagnosis of gastric cancer here. Hodgkin's lymphoma is a differential for supraclavicular lymphadenopathy, but it most commonly presents with cervical lymphadenopathy, not supraclavicular. So this is Trocheer's sign. Lump in the left supraclavicular region is called as Virchow's no. Clinical finding of Virchow's no is called as Trocheer's sign, indicative of gastric carcinoma. It is one of the first visible spots where metastasis occurs. Here, weight loss and reduced appetite are supporting the diagnosis of gastric cancer. Hodgkin's lymphoma can be a differential for supraclavicular lymph nodes, lymphadenopathy, but it is mainly commonly presenting with cervical lymphadenopathy most of the times. Okay, let's move ahead. Now, a 44-year-old man who has attended the emergency department multiple times in the past several months with complaints of upper abdominal pain. He develops episodes of pain lasting for weeks. There has been a gradual rise in his amylase level on every visit. He has had variety of investigation to explore the cause during his previous visits to the department. These include gastroscopy, an ultrasound which was found to be normal. On examination, his abdomen is soft, mildly tender at the epigastrium. What is the single most likely cause of his abdominal pain? Now, around 80% of chronic pancreatitis cases results from excess alcohol in developed countries. That this single line is very significant. 80%, around 80% of chronic pancreatitis cases results from excessive alcohol in developed countries. Given his recurrent presentation over several months, we can say this is a chronic case. Patients with chronic pancreatitis usually have constant and relapsing episodes of upper abdominal pain lasting for days or weeks. Constant and relapsing episodes of upper abdominal pain lasting for days or weeks. He would likely go on to have a CT scan of his abdomen, as the CT of pancreas is often the imaging modality of choice. Cystic fibrosis is incorrect here because it is a genetic disorder which affects people from birth and it's associated with respiratory complications. Furthermore, sadly, most of sufferers will not live beyond the age of 30 years in case of cystic fibrosis. So, in chronic pancreatitis, typically alcoholic or elderly patient, presentation is long-standing episodic epigastric pain radiating to the back, steatorrhea leading to malabsorption, leading to weight loss, and diabetes mellitus. Pancreatic calcification can be seen. Investigation fecal elastase, second ultrasound abdomen, and CT scan, contrast enhanced CT scan. These are the three investigations: fecal elastase, ultrasound abdomen, contrast enhanced CT scan. Amylase lipase are not as high as in acute pancreatitis, may even be normal. Treatment is with analgesics, pancreatic enzyme supplements, and fat soluble vitamins. So chronic pancreatitis, typically in alcoholic or elderly patient, presentation long-standing episodic epigastric pain radiating to the back, steatorrhea, malabsorption, weight loss, then diabetes mellitus. Steatorrhea, malabsorption, weight loss, and diabetes mellitus. Pancreatic calcification can be seen. Investigation fecal elastase, ultrasound abdomen, contrast in CT scan. Amylase lipase are not as high as in acute, may even be normal. Treatment is with analgesics, pancreatic enzyme supplements, and fat soluble vitamins. So we have to see that 80% of the chronic pancreatitis cases results from alcohol excess in developed countries. And patients with chronic pancreatitis usually have constant and relapsing episodes of upper abdominal pain lasting for days and weeks. And this patient can go on to have a CT scan of his abdomen as a CT of pancreas is imaging modality. Here, cystic fibrosis can be differential, but it would not be the correct answer because usually most of the sufferers with cystic fibrosis would not live beyond the age of 30 years, and it's a genetic disorder which affects people from birth and is associated with respiratory complications. So that will be the most likely cause of his abdominal pain, that is excessive alcohol intake. Case of chronic pancreatitis. Let's move ahead. Now we have 33-year-old woman having intermittent diarrhea, abdominal bloating, usually exacerbated by consumption of wheat and eggs. She has been feeling more tired in the past few months, no significant weight loss. Watch which condition should be first investigated. Now, the best answer here is celiac disease. Inflammatory bowel diseases such as Crohn's disease and ulcerative colitis can also cause malabsorption, but celiac disease should be investigated first, especially with the history of exacerbation with wheat intake. There is history of exacerbation with wheat intake. That's why we are more inclined towards celiac disease. Eggs usually do not exacerbate celiac disease since it does not contain gluten. However, her meals that contain wheat can cause her malabsorption symptoms. So, this is a case of celiac disease, and it should be investigated first because of the history of exacerbation of the condition with wheat intake. And yes, her meals which contain meat can cause her malabsorption symptoms due to celiac disease, due to sensitivity to gluten present in the diet. Let's move ahead. 45-year-old man had his head of pancreas removed due to malignancy. 10 days later, complaining of worsening abdominal pain. On examination, he has rigid abdomen, which is tender, temperature of 37.5, blood pressure 95/55, pulse rate 125. Past medical history includes peptic ulcer disease. What is the single most appropriate next action in this case? Now, this is a case of perforated peptic ulcer with features of shock, abdominal rigidity, raised temperature. Perforation of peptic ulcer causes an acute abdomen with a epigastric pain which progresses to generalized rigidity. The stress, uh, the stress like an operation may cause the body to produce higher amounts of acid. Yes, the stress like an operation may cause the body to produce higher amounts of acid, which can irritate pre-existing ulcers, leading to easy perforation. Diagnosis is made by taking an erect abdominal or chest X-ray, seeking air under the diaphragm. So the most appropriate next section in this case would be erect chest x-ray and abdominal x-ray. Not CT scan, not MRI, not ultrasound, not endoscopy. Erect chest x-ray and abdominal x-ray would be the answer here, would be the most appropriate next section, because this is a case of perforated peptic ulcer having features of shock, abdominal rigidity, and raised temperature. Perforation of peptic ulcer causes an acute abdomen with epigastric pain, which progresses to generalized rigidity. The stress, like an operation, may cause the body to produce higher amounts of acid, which can irritate pre existing ulcers, leading to easy perforation. Diagnosis is made by erect chest x ray or abdominal x ray, where we check for air under diaphragm, air under the diaphragm. Okay, let's move further. Next is 72-year-old woman having severe pain on the left lower abdomen. Started as a gradual ache 1 week ago but worsened acutely over the past 2 days. Her temperature is 38.6 degrees Celsius, heart rate is 90, respiratory rate is 19. On examination, tender mass is palpable at the left iliac fossa with the presence of guarding. What is the single most likely diagnosis in this case? Now, this woman is a 72-year-old lady. So, she's at an age where diverticular disease is common. One of the most common complications of diverticulitis is developing abscess. If an abscess was to form, she would have a very tender mass palpable with guarding. Now, another differential like sigmoid cancer does not usually present with fever and acute pain. In this lady, there is fever and acute pain. So this is not a case of sigmoid cancer, and also tubo-ovarian abscess is not likely in this age group. Appendicitis has features of pain, but on the right lower abdomen, not on the left lower abdomen. So appendicitis is having features of pain on the right lower abdomen, whereas this lady is having pain on the left lower abdomen. So not a case of appendicitis. Now abdominal angina. Abdominal angina occurs due to poor blood supply to the small intestines. The pain is usually epigastric or central abdominal. It starts around 15 minutes after eating, which is not the case here. So it is not a case of abdominal angina. This is a case of diverticular abscess. Not sigmoid cancer, because here we have fever, acute pain, such symptoms. Uh, which is not the case in sigmoid cancer. It is not tubo-ovarian abscess, not commonly found in this age group. Not appendicitis, because it is there is pain on the left lower abdomen, not on the right lower abdomen. In appendicitis, we have pain on the right lower abdomen. Now, abdominal angina, which is caused due to poor blood supply to the small intestine. In that, we have epigastric pain and central abdominal pain starts around 15 minutes after eating, which is also not the case here. So by ruling out, we can conclude that okay, this patient is at an age where diverticular disease is more common, and one of the complications of diverticulitis is developing diverticular abscess, developing an abscess. So in case of abscess, there would be a very tender mass palpable along with rigidity, along with guarding, sorry. So we have on examination a tender mass here palpable at the left iliac fossa with presence of guarding. This is a diverticular abscess. Now let's move ahead. Okay, so a 31-year-old female presenting with complaints of chest pain, difficulty in swallowing, liquids and solids. Her symptoms have been progressively worsening over the past year. She has also been suffering from recurrent chest infection for the past few months. What is the single most likely diagnosis in this case? Now, this is a case of achalasia cardia. The diagnosis here is achalasia. In achalasia, the dysphagia is often with both fluids and solids, and in fact, solids are affected more than soft foods or liquids. Now, it can sometimes present as chest pain or with recurrent chest infections. The chest infections or aspiration pneumonia results from untreated achalasia, which results in or which leads to nocturnal inhalation of material which is lodged in the esophagus and leading to aspiration pneumonia. So recurrent chest infections after the dysphagia indicates achalasia because there is also long past history of regurgitation and then develop dysphagia. If dysphagia is occurring first, then regurgitation or both together, then it is achalasia. If dysphagia occurs first and then there is regurgitation, then it is pointing towards achalasia. But if there is regurgitation and that is GERD and then the patient develop dysphagia, then it can be pointing towards peptic stricture. So no Shadsky ring is equals to only two solids, so no peptic stricture. No carcinoma because no typical cancer symptoms like weight loss. No Plummer-Vinson syndrome because no anemia or glossitis. Carcinoma, not a case of carcinoma because no typical cancer symptoms like weight loss. Not Shadsky ring because Shadsky ring is only to solids, whereas this is occurring both to liquids and solids at the same time. It is not peptic stricture because then they would be having history of GERD. Shadsky ring is actually an esophageal web that is commonly found in age of 50 and over. Presents with intermittent dysphagia to solids, usually marks the proximal part of a diaphragmatic hernia. The patient is too young here and there is dysphagia to liquids and solids both. Shadsky ring is only affecting the solids, dysphagia to solids. So diagnosis here is achalasia. Dysphagia is often to both solids and liquids, and it can sometimes present as chest pain or with recurrent chest infections. The chest infections or aspiration pneumonia results from untreated achalasia, which leads to nocturnal inhalation of material which are lodged in the esophagus and leading to aspiration pneumonia. Now let's move ahead. A 42-year-old obese woman presenting to emergency department with a 12-hour history of severe epigastric pain. The pain started suddenly, is seen to radiate to her back. If it is relieved when sitting forward. She is nauseous. She has vomited twice since the pain started. She drinks 1.5 glasses of wine per day. She has no significant past medical history. Pulse rate is 110. Tender in the epigastric region. What is the single most appropriate investigation in this case? So the likely diagnosis here is acute pancreatitis, and as we studied, serum lipase is more sensitive and more specific as compared to even serum amylase. So the most useful investigation in acute pancreatitis is serum lipase. Looking, and we have to look for an elevation of more than 3 times the upper normal limit. Now, while abdominal x-rays are not useful in the diagnosis of pancreatitis, they can be routinely ordered to exclude other potential causes of abdominal pain such as perforation or bowel obstruction. Ultrasound can be useful to detect the presence of gallstones, but it is not a good diagnostic test for acute pancreatitis. It is pancreatitis poorly visualized in ultrasound. Urea and electrolytes and liver function tests do not directly help in diagnosis of pancreatitis, but they are helpful in assessing the severity of the disease by showing the degree of leukocytosis or degree of hypovolemia, giving clues to the etiology of pancreatitis like gallstone pancreatitis. So, if there is characteristic pain along with serum amylase lipase level more than 3 times the normal level, then diagnosis of acute pancreatitis can be made. Serum lipase is more sensitive specific than serum amylase. So that is about acute pancreatitis and why serum lipase is the most useful investigation. More than 3 times the upper normal limit, and abdominal x-ray not useful in the diagnosis, but they can be ordered to rule out other causes of abdominal pain like perforation obstruction. Ultrasound can be used to detect gallstones, but not useful for the diagnosis of acute pancreatitis. Not clearly visible. Urea, electrolytes, liver function tests, not useful in the diagnosis of acute pancreatitis, but helpful in finding the severity of the disease, extent of the disease, showing the degree of leukocytosis, hypovolemia, etiology of pancreatitis like gallstone pancreatitis, etc. Next, a 49-year-old woman is brought to emergency with severe lethargy and a history of black tarry stools for the past 2 days. She has a medical history of rheumatoid arthritis and suffers from chronic anemia. She takes regular naproxen for pain relief. Her blood pressure is 80 by 40, heart rate is 119, blood test shows hemoglobin 52, reduced, white cell count 8, normal platelet count 390, almost normal. She was given IV fluids, 4 units of packed RBCs. Her heart rate is 107. Temperature is 37.1, blood pressure is 90 by 60 after the transfusion. What is the most appropriate next step in managing this patient? Now, black or tarry stools are used to describe bleeding in the upper part of the GI tract, that is esophagus, stomach, duodenum. The patient's GI bleeding is mostly linked to her long-term use of naproxen, that is NSAIDs, in the management of rheumatoid arthritis. So upper GI bleed is there. NSAIDs are notorious for their tendency to cause gastric ulceration, which can lead to erosion of a blood vessel, can lead to upper GI bleed. The patient is hemodynamically compromised here, provided that she is hypotensive and tachycardiac. Therefore, the priority in such a case is to bring about hemodynamic stability first, which has been attempted by giving IV fluids. Packed red cells were also given as she has hemoglobin of 52. An urgent endoscopy should follow to attempt to look for the source of bleeding and stop it. Endoscopy must be offered to unstable patients with severe acute upper GI bleed immediately after resuscitation, and similarly offered to all other patients with upper GI bleed within 24 hours of admission. So the patients who are unstable and having severe upper GI bleed, severe acute upper GI bleed, In those patients, immediately after resuscitation, endoscopy must be done urgently. Whereas in patients who are having upper GI bleed but are stable, in those patients also endoscopy must be performed within first 24 hours, within 24 hours of admission. While proton pump inhibitors certainly play an important role in the management of gastric ulcers, NICE guidelines advise that acid suppression, including H2 receptor antagonists, must not be prescribed to patients with a suspected non-varicose upper GI bleed prior to endoscopy. So prior to endoscopy, we should not give proton pump inhibitors or H2 blockers or any acid suppression treatment to patients before going for endoscopy. Two scoring systems which are important in such scenarios are Blatchford score at first presentation and Rockall score after endoscopy. So, if a patient is bleeding from suspected peptic ulcer and hemodynamically unstable, first stabilize the patient, give IV fluids. If stabilized, do endoscopy, then give after endoscopy, give proton pump inhibitors. Proton pump inhibitors or acid suppression treatment is not advised to be given before endoscopy. I think it is for at least 2 weeks. So non-varicose bleed, endoscopy before proton pump inhibitors. So again, black or tarry stools describing bleeding in the upper part of the GI tract, upper GI bleed from esophagus, stomach or duodenum. Now patients' GI bleeding is mostly linked in this case to the long-term use of NSAIDs, that is naproxen for rheumatoid arthritis, because they have tendency to cause gastric ulceration, which can likely cause erosion of a blood vessel. Now the patient is hemodynamically compromised provided that she is hypotensive and tachycardiac as well. Therefore, priority in such a case is to bring about hemodynamic stability. This has been attempted by giving IV fluids and pegged red blood cells. Pegged red cells have also been given because the hemoglobin was 52. An urgent endoscopy should follow to attempt to look for the source of bleeding and stop it. Urgent GI endoscopy should follow to look for the source of bleeding and stop it. Endoscopy must be offered to all the unstable patients with severe acute upper GI bleed immediately after resuscitation. So, in all the unstable patients with severe acute upper GI bleed, immediately after resuscitation, endoscopy must be done, and similarly, it should also be offered to all other patients with upper GI bleed within 24 hours of admission. Proton pump inhibitors help in the management of gastric ulcers, but NICE guidelines suggest that acid suppression therapy should not be given before endoscopy. Yes, acid suppression therapy like proton pump inhibitors, H2 receptor antagonists should not be prescribed to patients with a non-varicose upper GI bleed prior to endoscopy. In case of non-varicose upper GI bleed before endoscopy, two scoring systems which are useful in such scenarios: Blatchford score at first presentation and Rockall score after endoscopy. Blatchford score during presentation and Rockall score after endoscopy. These are the two scoring systems. Now, a 43-year-old male alcoholic presents after a large hematemesis. He has some spider nevi on his chest. Blood pressure is 100 by 76. Pulse rate is 110 on examination. Swollen abdomen with shifting dullness is seen. Now, what is the single most likely diagnosis in this case? Now, spider nevi and ascites. Both of these things are suggestive, both of these features are suggestive of liver disease. It is likely that with the history of alcohol and his signs and symptoms. He has a diagnosis of chronic liver disease, which has resulted in portal hypertension and bleeding from esophageal varices. Let's go through this chart quickly of upper GI bleed. Melena, black tarry stools. If hemodynamically compromised, start with IV fluids. If hemoglobin is low, start giving red blood cells after resuscitation of the patient. Do urgent upper GI endoscopy. Okay, yes, that's what we studied just now. Okay, so we were studying about esophageal varices. These are dilated submucosal veins in the lower third of the esophagus. This can lead to variceal hemorrhage, which results from the dilated veins at the junction between portal and systemic venous systems. The bleeding is often severe and life-threatening. Majority of the patients would have a history of chronic liver disease. Presentation would be hematemesis, melena, and signs of chronic liver disease. Investigation would be endoscopy at early stage. Management of variceal bleeding always start with ABC, airway, breathing, circulation. And correct the clotting. Correct clotting. FFP, we can give FFP, vitamin K. Vasoactive agents like terlipressin should be offered to patients with suspected variceal bleeding at presentation. Antibiotic prophylaxis reduces mortality in patients with upper GI bleed in association with chronic liver disease. Endoscopic variceal band ligation. If it is not available, use emergency sclerotherapy as the first line. Senks taken Blakemore tube if there is uncontrolled hemorrhage. Transjugular intrahepatic portosystemic shunt, that is TIPS. TIPS is transjugular intrahepatic portosystemic shunt if we are still unable to control bleeding. Prophylaxis of variceal hemorrhage. Propranolol often given at discharge to reduce the portal pressure in order to decrease the risk of repeat bleeding. So again, spider nevi and ascites, these are suggestive of liver disease. So it is likely that with the history of alcohol intake, signs and symptoms, the patient has a diagnosis of chronic liver disease, which has resulted in portal hypertension and bleeding from esophageal varices. Bleeding from esophageal varices, and there is portal hypertension due to chronic liver disease. Now, esophageal varices, these are dilated submucosal veins in the lower one third of esophagus. What are esophageal varices? These are dilated submucosal veins in the lower one third of the esophagus, and this can lead to variceal hemorrhage, which occurs from the dilated veins or dilated varices at the junction between portal and systemic venous systems. This bleeding can be very severe sometimes and it can be life threatening as well. Majority of these patients would have a history of chronic liver disease. Now, presentation of esophageal varices would be now major presentation of these patients Uh, Majority of these patients would have a history of chronic liver disease in esophageal varices, and presentation would be hematemesis most commonly and melena, and signs of chronic liver disease. Hematemesis, melena, and signs of chronic liver disease. Hematemesis is most common in esophageal varices. Now, investigation. Here, investigation is endoscopy at early stage. Now, acute management. Acute management of varicose bleeding. Always start with ABC, airway breathing circulation. Then correct the clotting. That is, give FFP or vitamin K. Then vasoactive agents like terlipressin can be used. Then antibiotic prophylaxis can be used for reducing the mortality in patients with upper GI bleed in association with CLD. Then endoscopic variceal band ligation. Endoscopic variceal band ligation, if it is not available, then sclerotherapy, then Sangstick Blakemore tube in case of uncontrolled hemorrhage, and if nothing works out, then TIPS. TIPS is transtubular intrahepatic portosystemic shunt. So ABC, then correct clotting by FFP and vitamin K, then terlipressin vasoactive agent, and antibiotic prophylaxis to reduce mortality, then endoscopic varicose band ligation. Endoscopic varicose band ligation not available, then sclerotherapy, Sangstick Blakemore tube in case of uncontrolled hemorrhage. If nothing works out, then TIPS, that is transtubular intrahepatic portosystemic shunt. Now, prophylaxis, propranolol. Propranolol can be given at the time of discharge so as to reduce portal pressure in order to decrease the risk of repeated bleeding. Now, let's take a break for a while and I'll be back. Okay, so now we have a 40-year-old woman admitted to the hospital for management of a pulmonary embolism, which was diagnosed 3 days ago. She starts having epigastric pain over the past few hours, has bouts of diarrhea. There is no blood in her stools. She feels nauseous but has not vomited. What is the single most likely reason for her symptoms? So now, gastroenteritis is very common in hospitals, especially with the spread of norovirus. They present with acute onset of diarrhea, sometimes with vomiting and abdominal pain. In this particular question, the area of pain is epigastric rather than central. Patients with gastroenteritis should be isolated, given a single side room until diarrhea resolves. So, after 3 days of admission, patient develops diarrhea. This is pathognomonic for gastroenteritis, that is norovirus, and needs to be isolated in a separate room. This should be remembered. So, if patient after admission for a few days develops diarrhea, then this is pathognomonic for gastroenteritis caused due to norovirus, and this patient needs to be isolated in a separate room. Gastroenteritis is very common in hospitals, especially with the spread of norovirus, and this patient can present with acute onset of diarrhea, sometimes with vomiting and abdominal pain. In this particular question, area of pain is epigastric, not central. Patient with gastroenteritis should be isolated, given a single site room until diarrhea resolves. Now let's move ahead. Next, 55-year-old man with no past medical history comes to your office for the evaluation of difficulty swallowing foods. He has had this problem for almost a year, finds it difficult for him to swallow both solids and liquids. Now, a barium meal shows gross dilatation of the esophagus. Now, barium meal shows gross dilatation of the esophagus with a smooth narrowing at the lower end of the esophagus. Barium meal is showing gross dilatation of the esophagus with a smooth narrowing at the lower end of the esophagus. What is the single most likely diagnosis here? So this is typical bird's beak appearance which we see on barium meal, which is showing evidence of achalasia. Bird's beak appearance at the distal end of esophagus. There is difficulty in swallowing both solids and liquids simultaneously, which is seen in achalasia. Now let's move ahead. A 44-year-old woman has been experiencing chest pain, nausea, vomiting. Over the past few days, she has burning sensation in her chest. A chest x-ray shows the presence of an air fluid level in a mass behind a normal size heart. What is the single most likely diagnosis in this case? So this is a case of hiatus hernia. The hiatus hernia can present with an air fluid level in a mass that is behind the heart. Her features are also consistent with hiatus hernia. Achalasia findings are rarely seen on chest x-ray, so this is not a case of achalasia. If any, they would include a vastly dilated esophagus behind the heart, and air fluid levels can be found in thoracic esophagus, but they are uncommon. Remaining options like scleroderma, bulbar palsy, pharyngeal pouch would not present with air fluid levels on the chest x-ray. So let's read a little about hiatus hernia. Now hiatus hernia, first we'll study types. of hiatus hernia. First, let's go through the chart. Hiatus hernia presentation is gastroesophageal reflux symptoms and some may be asymptomatic. Diagnosis is by endoscopy and barium swallow. Role of chest x-ray. In chest x-ray which are done for other reasons, example in patients who are having chest pain, they can show soft tissue opacity with air fluid level behind the heart. So routine chest x-rays which are done for other patients with chest pain, uh, those chest x-rays can sometimes show soft tissue opacity and air fluid level, soft tissue opacity with multiple air fluid level, soft tissue opacity with air fluid level behind the heart, which is pathognomonic for hiatus hernia. So air fluid level behind the heart. So this is the picture which is given to remember. Air fluid level behind the heart, soft tissue opacity with air fluid level behind the heart seen on chest x-ray. So this denotes hiatus hernia. So presentation is gastroesophageal reflux symptoms or asymptomatic. Diagnosis is by endoscopy and barium swallow. Role of chest x-ray. So chest x-ray done for other reasons. For example, in patients with chest pain, we can see, or for the same reason, we can see soft tissue opacity with air fluid levels behind the heart. So air fluid level behind the heart in chest x-ray is pathognomonic of hiatus hernia. Now the types. Let's study about the types now. Sliding, rolling. These are the two types of hiatus hernia. Sliding type accounts for 95% of the cases. Gastroesophageal junction slides above the diaphragm. In this case, gastroesophageal junction, it slides above the diaphragm. Whereas rolling type, which is also called as paraesophageal, which accounts for 5% of the cases, in this, gastroesophageal junction remains below the diaphragm itself, but a part of the stomach herniates through the esophageal hiatus. Part of the stomach herniates through the esophageal hiatus. So this is rolling type of hiatus hernia. 5% of the cases paraesophageal. Presentation may be asymptomatic, may be gastroesophageal reflux symptoms that we studied, retroesternal burning sensation, especially when bending or lying down. Investigations are endoscopy, barium swallow, and esophageal manometry, only if surgery is being considered. Chest x-ray is done for other reason, that is chest pain, can show soft tissue opacity with air fluid level behind the heart. Red flag symptoms like weight loss, dysphagia needs an urgent endoscopy to look for other sinister causes. So red flag symptoms like weight loss or dysphagia needs an urgent endoscopy. Management is by medical and surgical. Medical management is proton pump inhibitors. Surgical management is laparoscopic fundoplication. Laparoscopic fundoplication considered if there is persistent symptoms like regurgitation, intractable cough, or esophagitis. Fundoplication or fundoplication. So medical management, proton pump inhibitors. Surgical management, laparoscopic fundoplication. It is considered if there are persistent symptoms like regurgitation, intractable cough, or esophagitis despite the medical management. So two types of hiatus hernia, sliding type and rolling type. Sliding type more common, about 95% of the cases are sliding type. In this GE junction, that is gastroesophageal junction, it slides above the diaphragm. Okay. Rolling type, also called as paraesophageal, only 5% of the cases. In this, the gastroesophageal junction is still below the diaphragm, but in this, a small part of the stomach herniates through the esophageal hiatus. It herniates above through the esophageal hiatus. This is called as rolling type of hiatus hernia, 5% of the cases. Presentation, we studied GE gastroesophageal reflux symptoms, that is retroesternal burning sensation. retrosternal burning sensation, especially on bending and lying down, or can be asymptomatic as well. Investigation endoscopy, barium swallow, and esophageal manometry. Only if surgery considered, then esophageal manometry. Barium swallow to for diagnosis, endoscopy for detecting complications. Chest x-rays, which are done for other reasons such as chest pain, can show soft tissue opacity with air fluid level behind the heart. Now this is pointing towards hiatus hernia. Red flag symptoms like weight loss and dysphagia. In those cases, urgent endoscopy should be done to rule out other sinister causes. Management, medical and surgical. Medical management, proton pump inhibitors in hiatus hernia. Medical management, proton pump inhibitors. Surgical management, laparoscopic fundoplication. Now it is considered if there are persistent symptoms like regurgitation and esophagitis as well as intractable cough even after medical management. Now let's go through the chart. So here we can see both the types here. We can see both the types, sliding and rolling. Sliding gastroesophageal junction, sliding of the diaphragm. We can see in the picture. Rolling gastroesophageal junction remains below the diaphragm, but a part of the stomach herniates to the esophageal hiatus. It is rolling type. Sliding and rolling. Okay. Now let's move ahead. Let's move further. But if we see air fluid level in upper mediastinum, then it would be pharyngeal pouch. If air fluid level behind the heart, hiatus hernia, air fluid level in upper mediastinum, that is pharyngeal pouch. Hiding behind the heart, hiatus hernia. Okay, let's move ahead. Now, next we have 42-year-old female presenting to her GP following a staging CT for a recently diagnosed renal cell carcinoma. On the CT scan, gallstones were noticed in the gallbladder. No history of abdominal pain or jaundice, is otherwise well. Left-sided nephrectomy for a renal cell carcinoma has been scheduled. What is the single most appropriate course of action? Now, reassurance is the most appropriate action here. It is reserved for patients who are asymptomatic and they have stones in their gallbladder. Stones that are found incidentally as a result of imaging investigations unrelated to gallstone disease in patients who are asymptomatic do not require any intervention. But be aware that if the gallstones were found in the common bile duct instead of the gallbladder, then a laparoscopic cholecystectomy may be needed regardless if the symptoms are present or not. So, if the patient is asymptomatic and stones are present in the gallbladder and it is an incidental finding, then we have to reassure the patient. But if the patient is even asymptomatic and the gallstones are found in common bile duct and it is an incidental finding, then even if they are asymptomatic or symptomatic, we have to carry out laparoscopic cholecystectomy in that case. So, if the patient is asymptomatic and having gallbladder stones, having inguinal hernia, or even hemorrhoids, then no treatment is required, only reassurance. Now, if The patient is either symptomatic or asymptomatic. If the patient is having stones in the common bile duct or having femoral hernia, then yes, treatment is required in that case. So this we have to remember here. So if there is a patient who is having stones in the gallbladder and the patient is asymptomatic, or if the patient is having hiatus, sorry, if the patient is having inguinal hernia and the patient is asymptomatic, or if the patient is having hemorrhoids and he or she is asymptomatic, in all these cases, gallbladder stones, inguinal hernia, and hemorrhoids. If the patient is asymptomatic, then no treatment is required, only reassurance is sufficient. But if we have stones present in the common bile duct, if we have common bile duct stones, or we have femoral hernia, in both these cases, we have to carry out treatment. For example, in common bile duct stone, if there is stone in the common bile duct, then we have to carry out laparoscopic cholecystectomy, regardless of if symptoms are present or not. If gallstones are present in common bile duct, then we have to carry out laparoscopic cholecystectomy. If the gallstones are present in gallbladder, if the stones are present in gallbladder, patient is asymptomatic, no need. Reassurance is sufficient. Okay, now let's move ahead. Next, while performing an appendicectomy, a surgeon found a mass in the cecum of the patient. The mass was removed, sent for analysis. Analysis revealed a transmural infiltration with lymphocytes and granulomas without necrosis. What is the single most probable diagnosis here? Now, this is a difficult question to answer as there is not much background information in terms of patient history, signs or symptoms, in terms of patient's presentation. Based on the histology, we would be tempted to choose Crohn's disease as a diagnosis, as Crohn's disease is known to have histopathology of abdominal mass palpable in right iliac fossa, increased goblet cells, increased granulomas seen on histology, transmural skip lesions and cobblestone appearance seen on endoscopy, and Cantor's string sign, rose thorn ulcers, and fistula are seen on small bowel enema. So on small bowel enema, we'll see Cantor's string sign, rose thorn ulcers, and fistula. So these are also important. Abdominal mass palpable on right iliac fossa, increased goblet cells and granulomas on histology, transmural skip lesions and cobblestone appearance on endoscopy, and on enema, on small bowel enema, we'll see Cantor's string sign, rose thorn appearance, and fistula. Now, based on the histopathology alone, the correct answer here is Crohn's disease. In reality, the patient would present with classical signs and symptoms of Crohn disease, like patient will have diarrhea, may have diarrhea which may be patient may have diarrhea which may be bloody and can become chronic, is present for more than 6 weeks, or there can be abdominal pain, weight loss, periods of acute exacerbation interspersed with remissions or less active disease, systemic symptoms like fever, anorexia, malaise, then abdominal tenderness, distension, palpable mass. There can be abdominal tenderness, abdominal distension, palpable masses. There can be anal and perianal lesions as well, which are characteristic. Anal and perianal lesions like pendulous skin tags, abscesses, and fistulas. These are characteristic. Anal and perianal lesions like pendulous skin tags, abscesses, and fistula, and mouth ulcers. Mouth ulcers. Additional points to remember are to diagnose ulcerative colitis or Crohn's disease, fecal calprotectin, AXR to exclude colonic dilatation, abdominal x-rays to exclude colonic dilatation, stool examination, barium fluoroscopy, that is barium enema, and sigmoidoscopy, colonoscopy plus biopsy. And management, we already know: inducing remission, maintaining remission, ulcerative colitis, topical rectal mesalazine better than rectal steroids, first line, including oral mesalazine, second line oral prednisolone. If severe colitis, treat in hospital with IV steroids as first line, maintaining with maintaining remission with oral aminosalicylates such as mesalazine. Management of Crohn's disease, inducing remission, first line, oral corticosteroids, like oral prednisolone. Now here first line is oral prednisolone, second line aminosalicylates like mesalazine, and azathioprine or mercaptopurine may be used as an add-on medication to induce remission, but it is not used as monotherapy. Metronidazole is often used, maintaining remission by azathioprine or mercaptopurine. So fecal calprotectin, abdominal x-rays, stool examination, fecal calprotectin, stool examination, barium studies, barium fluoroscopy, and abdominal x-rays, and sigmoidoscopy, fluoroscopy, sorry, sigmoidoscopy, colonoscopy plus biopsy. So endoscopy, that is sigmoidoscopy, colonoscopy plus biopsy. These are the investigations used to diagnose ulcerative colitis or Crohn's disease. Okay, so now let's move ahead. A 12-year-old child complains of right iliac fossa pain, diarrhea that has worsened over a period of weeks. He was referred to gastroenterology team for further management. On colonoscopy, transmural cobblestone appearance, mucosa is seen near the ileocecal junction. Which of the following can be used as monotherapy to induce remission? So now this is because there are characteristic features. So this is a case of Crohn's disease. Now we know in management of Crohn's disease, corticosteroids. First line, oral prednisolone. So oral corticosteroids, and then second line we can use oral aminosalicylates like mesalazine. This is for inducing remission. For maintaining remission, we use azathioprine, mercaptopurine, other drugs. So, diagnosis of Crohn's disease is quite clear here. Transmural cobblestone appearance mucosa is a giveaway. Now, corticosteroids or glucocorticosteroids such as prednisolone is the first line, but it is not given in the options here. So, mesalazine, that is the second line treatment in inducing remission of Crohn's disease. Mesalazine is an aminosalicylate which can be used as monotherapy for those with mild to moderate Crohn's disease where conventional glucocorticosteroids are contraindicated. Mercaptopurine can be used as an add-on medication to induce remission, but it should not be used as monotherapy. Azathioprine, mercaptopurine, they cannot be used as monotherapy, can be used as an add-on. So first line would be oral corticosteroids like oral prednisolone. Second line would be oral aminosalicylates like mesalazine. So mesalazine is given here. It can be used as monotherapy in mild to moderate cases. Okay, let's move ahead. Next, we have 41-year-old man with type 2 diabetes mellitus presenting to the clinic with complaints of pain in his joints, unusual increase in breast size. He feels increasingly fatigued. Over the past few months on examination, there is a deep tan color of his skin. His liver is enlarged on palpation. What is the single most likely diagnosis in this case? Now, the deep tan color of the skin with the combination of diabetes is termed bronze diabetes, and it is seen in hemochromatosis. The iron overload can also cause symptoms like arthropathy and gynecomastia. So let's study a little about hemochromatosis. In We know hereditary hemochromatosis is an autosomal recessive genetic disease in which there is increased intestinal absorption of iron, causing accumulation in tissue, especially liver, leading to organ damage. It can also affect the iron deposition, can also affect pancreas. Other organs which are affected are pancreas, joints, heart, skin, and gonads. Presentation: early diagnosis is difficult because often asymptomatic. Symptoms usually start in the age of 40 to 60. Initial symptoms are vague, non-specific like fatigue, weakness, heart problems. It is diagnosed incidentally following abnormal serum ferritin level or deranged LFT. Symptoms of advanced disease include diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac disease like arrhythmias, cardiomyopathy, neurological or psychiatric symptoms like impaired memory, mood swings, irritability, and depression. So, advanced symptoms of advanced disease in hemochromatosis are diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac disease like arrhythmia or cardiomyopathy, neurological psychiatric symptoms like impaired memory, mood swings, irritability, and depression. So we have to remember a triad in hemochromatosis, a triad of diabetes, hepatomegaly, and bronze pigmentation. A triad of diabetes, bronzing of the skin, and hepatomegaly. Diabetes, bronzing of the skin, and hepatomegaly. This is a triad seen in hemochromatosis. Symptoms of advanced disease: diabetes, bronzing of the skin, hepatomegaly, cirrhosis. Diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac symptoms like arrhythmias and cardiomyopathy, neurological psychiatric symptoms like irritability, mood swings, depression, impaired memory, etc. Triad of diabetes, bronzing of the skin, and hepatomegaly. So This is about hemochromatosis, and due to iron overload, there can be arthropathy as well as gynecomastia can be there. So deep tan color of the skin with combination of diabetes, bronze diabetes. This is called. We studied the triangle, the triad of diabetes, bronzing of the skin, and hepatomegaly in hemochromatosis. Now both tanning of the skin and diabetes together can be termed as bronze diabetes seen in hemochromatosis. Okay, now let's move ahead. Next, we have a 59-year-old man having multiple liver metastases with the primary tumor originating from the large bowel. He has abdominal pain, jaundice. On general inspection, he looks cachectic and drowsy. He has significant ascites, edema on both ankles. Family have concerns that he is not having sufficient fluids orally. Urine output is low. Currently takes regular haloperidol 1.5 mg 3 times a day, lactulose 10 ml twice. Urea is 6.2, creatinine 85, sodium 129, calcium 2.42, potassium 3.6, albumin 18, bilirubin 105, alkaline phosphorus 411. What is the single most appropriate management in this case? So this patient has hypoalbuminemia. When plasma proteins, especially albumin no longer sustains sufficient colloidal osmotic pressure to counterbalance the hydrostatic pressure, it leads to edema and ascites. Now, intravenous albumin may be used to increase blood colloidal osmotic pressure to draw fluid back into the intravascular compartment to reduce the edema as well as ascites. It restores intravascular plasma volume with less exacerbation of salt and water overload than isotonic solutions. So there is less exacerbation of salt and water overload as compared to isotonic solutions. Now, albumin infusion produces only a transient effect, but it is useful in cases like this where surgery may not be an option and treatment of intravascular fluid deficit and edema is required. It is also useful to obtain diuresis in hypoalbuminemic patients. Haloperidol has got no role in causing hypoalbuminemia. So ascites due to cirrhosis, we can give spironolactone, then albumin. Ascites due to metastasis, we can give albumin. So if ascites is due to cirrhosis, then we have to give spironolactone first and then albumin. If ascites is due to metastasis, then we can directly give albumin. So management of a patient with liver cirrhosis with ascites plus minus fever. If cirrhosis is there, then we can give spironolactone. Patient with cirrhosis with ascites. If cirrhosis is there, then we can give spironolactone. If fever is present, then investigation, that is ascitic fluid aspirate analysis, ascitic fluid aspiration and its analysis. If high neutrophils in aspirate, then we can give IV antibiotics. So this is the management of a patient with liver cirrhosis with ascites and fever. So in case of cirrhosis, we will give spironolactone. We will give spironolactone. If fever is present, then we have to carry out an investigation, that is ascitic fluid tapping and fluid analysis, ascitic fluid analysis after aspiration. Then if there is high neutrophil count in ascitic fluid, if there is high neutrophils in ascitic fluid aspirate, then we will give IV antibiotics. So the patient is having hypoalbuminemia when plasma proteins, especially albumin, no longer are sustaining sufficient colloidal osmotic pressure, then it can lead to edema and ascites. Intravenous albumin may be used to increase the blood colloidal osmotic pressure, intravenous colloidal osmotic pressure, so as to draw the fluid back into the intravascular compartment and reducing the edema and ascites. It restores intravascular plasma volume with less increase or less exacerbation of salt and water overload as compared to the isotonic solution, because we can also give isotonic solutions to increase intravascular volume, but that can cause increase in salt and water overload, that can cause exacerbation of salt and water overload, whereas directly giving intravenous albumin, it helps in restoring the intravascular plasma volume with less exacerbation of salt and water overload. So albumin infusion produces only a transient effect, but it is useful in these cases where surgery may not be an option and treatment of intravascular fluid deficit and edema is required. It is also useful to obtain diuresis in these hypoalbuminemic patients. Haloperidol has no role in this case in causing hypoalbuminemia. So if ascites is caused due to cirrhosis, then we will give spironolactone and then we will give albumin. But if ascites is caused due to metastasis, then we will directly give albumin. And if cirrhosis, we will give spironolactone, and if fever is present, then investigation, ascitic fluid tapping, ascitic fluid aspiration, analysis. If high neutrophils in the aspirate, then IV antibiotics. Let's go through certain charts here. Elective esophagogastroduodenoscopy or elective upper GI endoscopy. It is done using anesthetic throat spray or IV sedation, not general anesthesia. Still needs 6 hours of no food before procedure. This is to ensure a good view of the stomach by the operator. If patient had just eaten a few hours ago and attends for a morning OGT, the best plan would be to defer the procedure till late afternoon. This will give adequate time for the stomach to become empty. Stomach to empty. Okay, so this is elective upper GI endoscopy, elective esophagogastroduodenoscopy. It is done using anesthetic throat spray or IV sedation. Anesthetic throat sprays or IV sedation, not general anesthesia. And but it still needs 6 hours of no food before the procedure. This is to ensure a good view of the stomach by the operator. If patient had just eaten few hours ago by mistake and attends for morning upper GI endoscopy, then best plan would be to defer the procedure till late afternoon, which will give adequate time for the stomach to empty. Now, colonoscopy or stool MCS. Occasionally, the exam may give a scenario of an elderly patient who has diarrhea and blood in the stool. If asked what test to do, then initial stool microscopy, culture and sensitivity appropriate. Most initial would be stool microscopy, culture and sensitivity. Most appropriate would be colonoscopy. Okay, so if there is a scenario of an elderly patient who has diarrhea and blood in stool, then what is the most initial investigation which should be done? Most initial investigation is stool microscopy, culture and sensitivity. Most appropriate Most appropriate is colonoscopy. Most appropriate is colonoscopy. Most initially is stool microscopy, culture, and sensitivity. Okay. Now this is Mackler's triad in esophageal rupture that includes chest pain, vomiting, and subcutaneous emphysema. Subcutaneous emphysema is a late sign of esophageal rupture. In esophageal rupture, Mackler's triad. We have Mackler's triad in esophageal rupture, which has vomiting, chest pain, and subcutaneous emphysema. Subcutaneous emphysema being a late sign of esophageal rupture. One of the complications of esophageal rupture is mediastinitis, which is characterized by fever, chills, and retrosternal pain. Complication of esophageal rupture, mediastinitis, characterized by fever, chills, and retrosternal pain. Yes. A child with elevated liver enzymes, slow deterioration in school performance. On examination, there is hepatosplenomegaly, intentional tremors, dysarthria, dystonia. What is the diagnosis? Wilson's disease. So we should remember this is the scenario for Wilson's disease. Child with elevated liver enzymes, slow deterioration in school performance, and there is hepatosplenomegaly, there is dysarthria, dystonia, as well as intentional tremors. Intention tremors. The diagnosis is Wilson's disease. Now, a 55-year-old man presenting with abdominal discomfort, and he has long-standing rheumatoid arthritis, taking methotrexate regularly, has naproxen twice daily. His hemoglobin is seen to be low, MCV is low. What is the likely cause of his laboratory finding? Chronic GI bleed. The clincher here is abdominal discomfort, which implies bleeding. If there was no option of chronic GI bleed or iron deficiency, then we will pick anemia of chronic disease, which for rheumatic disease usually produces microcytic anemia. Okay, so this is chronic GI bleed scenario. So what is the most common cause of vitamin B12 deficiency in the United Kingdom? This is pernicious anemia, lack of intrinsic factor secretion in the stomach, leading to poor absorption of B12 in the ileum. Causes: veganism, total gastrectomy, lack of intrinsic factor, ileal resection, Crohn's disease, chronic pancreatitis, celiac disease. Now this is pernicious anemia, in which we have autoimmune atrophic gastritis causing B12 deficiency. In pernicious anemia, there is autoimmune atrophic gastritis causing B12 deficiency. Features are megaloblastic anemia, paresthesia, numbness, subacute combined degeneration, severe B12 deficiency associated with other autoimmune disease like type 1 diabetes, Hashimoto's disease, vitiligo, hypoadrenalism. Investigation is by intrinsic factor antibody and Schilling test. Schilling test. Intrinsic factor antibody has high specificity, and Schilling test is done to measure B12 absorption. Schilling test is done to measure B12 absorption. Okay. Treatment is hydroxycobalamin. Okay, so this is about gastroenterology. We have tried to touch almost all the topics. Okay, then take care. See you next time.